This is Duke University.
Since becoming Duke's 9th president in 2004, President Broadhead has ushered in a new era of expansion, investment, and altruism at Duke. And from the creation of the Duke Global Health Institute and the success of our financial aid initiative to the launch of our civic service program, Duke Engage, President Broadhead has been a true leader for our university, and it is my pleasure to turn the podium and your attention over to our president, Dick Broadhead. Thank you.
Well, that was very fun. I only wanted to clarify that the person who jumped up on the press box to salute was the Blue Devil and not me. And I would also comment, and this will be my last comment on yesterday, that I spent lunchtime at Miami, and I couldn't help reflecting how pleasant it is to have Miami come play us. Maybe next year we'll schedule several more games with them and fewer games with some other people. Anyway, it's very nice to be here. This is a very, very beautiful spot, and I've met lots of great people. And of course, a university community has so many different people who probably don't know each other or their connection, except your lives have all passed through the force field of this university, and so it's logical to draw you together. Here's the format. I'm going to talk a little while about things at Duke, just so you'll be up to date. And then I'll ask my colleague and pal, Victor Dzau. We are both hoping that the lights will go on in my ersatz office, which seems to have suffered a blown fuse or something at the moment. And I will then just sort of ask him some obvious questions on your behalf, and then we'll throw it open and you can ask your questions of either Dr. Dzau or myself. So just a few things about Duke nowadays, just to catch you up. This has been, as everyone understands, an extremely turbulent year in the world, and thus also for Duke. But if you had been on campus, I think what you would say is it has just been a year of extraordinarily high spirits, one great thing after another, lots and lots of positive energy and momentum. The year began, we welcomed our freshmen on a Wednesday, and the next night we all went to the Nasher Museum to open the exhibit of work from El Greco to Velázquez, hailed by Time magazine in the year-end issue as the third best art exhibit in America last year. All right, now, yeah. Now, when you consider that museum didn't exist 5 years ago, you realize that is a pretty great accomplishment. That weekend, we had our opening football game, and I used to have the not entirely enviable distinction of being the president of an American university with the longest non-winning streak. This has been changed. We got a new coach, and what was so wonderful was not only did we win a number of games and make a number of other ones competitive, but that was done with our very same players. David Cutcliffe will, over time, be able to recruit his own players, but he started with what we had, and he taught them that by working hard, they could succeed, and that was very fun for all of us. And wasn't it an enjoyable day for me when walking to Wallace Wade Stadium to the North Carolina State game, someone tried to sell me a ticket to a Duke football game for a very sizable sum. In future, I hope that the price will get higher and higher. And I do urge you to buy your season tickets now. Another fun event of the fall, I'm picking events not entirely at random, but I have plenty to choose, was the day in November when we reached our goal of raising $300 million for financial aid endowment. Duke has always had the right policy on financial aid, which is we admit students based only on their qualifications, and then we meet their need to make it affordable to come there. And I've talked to some of you who went through a school at Duke on financial aid, and I just want to say that's what a university should be. Its doors should be wide open to talent, and so we set out in plush times to raise that money, and we just succeeded, and I'll tell you, aren't we glad we did that now? Because now when people tell us in the middle of the year that their mom or dad doesn't have a job anymore, we have the funds to guarantee that commitment going forward. So that's a good thing. I would say, too, you name me the field, and I'll tell you the interesting person from that field who was on campus this fall. Not just on campus, but what we really tried to do this fall was to have not just people come do celebrity gigs, but to come and spend lots of time with small groups of students. Tom Friedman's new book came out, Hot, Flat, and Crowded. It came out the first week of September. The second week he was at Duke, where he not only gave a public lecture to about 1,800 people, but he attended classes all afternoon and well into the evening until even that person was worn out. That's my goal, is to wear these people out, sharing their thoughts with that of their successors. Who's Tom Friedman? He was somebody who was an undergraduate or a graduate student once upon a time, and so the students of today should be able to activate their powers by interchanges with the likes of him. Justice Kennedy came to open the wonderful new extension to our law school and gave just a marvelous meditation on the meaning of law and what it provides to a culture and where it came from. Michelle Rhee, whose name you may know, the woman who became the superintendent of schools in Washington, D.C., the city with the lowest performance rate of any school system in America in this nation's capital, chosen to head that school system when she was 37 years old. She is a person of gusto and guts, and she came and talked about education issues, talked in public, talked to our students, talked to the local school board. It was just a great, great visit. Martin Luther King Day, Reverend Joseph Lowery, who was the person who co-founded the Southern Christian Leadership Conference with Martin Luther King, came to Durham and spoke, and then as he left Duke Chapel, had to catch the plane to continue on to the inauguration, where he gave the benediction. So it's just been a fun time to be on campus. Just every day there's something, and all different kinds of things. You're all too old to watch The Office, aren't you? But the guy who writes The Office is going to do a stand-up comedy skit in Page Auditorium in about 2 weeks, and he is what we might say the Justice Kennedy of a different set. So it's been a very exciting year, just lots of sense of animation and possibility. Of course, we are not unmindful of the external world. We are protected from it in certain ways, but everyone lives in the same world, and so we will have our own version of dealing with new facts. The university has an endowment. That's a good thing. The value of our endowment has gone down about 20% since last year. That's not a good thing. But truth to tell, the university, like everyone in the world, got used to rising income levels far above what anyone ever expected or prophesied for a long time. And if the day comes when we need to go through some self-discipline to refocus our activities at a somewhat different budgetary level, that could be a salutary exercise if you do it in the right spirit, and I'm confident we will. I would just say 3 things about Duke in the middle of this economic crisis. One will be clear to you: you'd rather be in our industry than many others because we are an all-season, all-weather industry. People don't cease needing higher education when an economic crisis comes. Indeed, our applications have gone up in every school, and they went up a total of 3,500 more applicants this year than last to our undergraduate school. So that's kind of interesting to contemplate. The second is Duke used the prosperity of recent years not just to develop new habits of consumption, but to build things that add enduring strength to the university. A museum was added during that time. You don't need to build a new museum every year. Once you've got one that attracts Velázquez and El Greco, you're doing pretty well. We've built over $1 billion of new buildings in the last 8 years. We have science labs, engineering labs, museums, libraries, all kinds of things we didn't used to have, and life will be permanently enriched as a result of those, even if we now go through a leaner period. And the third thing I say with the most feeling, and it's just this. The story of Duke was never the story of waiting till you had tons of resources and then figuring out how to spend them. The story of Duke was always having bright and innovative ideas in an entrepreneurial spirit and just trying things and then attracting the resources by the ingenuity and creativity of the people you had there. Victor's about to come on stage. Victor heads what is widely recognized as one of the top 5 or 6 academic medical centers in the world. But what was that place 80 years ago? It was a forest. It was a pine forest, and somebody had the idea that you could actually create a great medical center out of, well, at least that wasn't you this time, Sterling. Somebody had the idea that you could create a great center of medical research and patient care in the middle of a forest, and it came to pass. We went to the memorial service within the last 10 days for David Sabiston, a giant of Duke medicine, the head of surgery, the person who did the first cardiac bypass operation. So it's the kind of place where people have always had, where the ideas came before the resources and attracted the resources in some measure. And I say to myself, if that's been the history of this university, then let it continue to be the history of this university. This will not be a time when we stop having good ideas and using our imagination to come up with better ways of doing things. I would say in particular, there's something we really are more or less self-consciously trying to do at Duke. We do have the understanding universities are wonderful treasures of our culture. They preserve many things that need preservation. But I think it is now growingly clear that in the future, people will need things from universities different from what universities are used to supplying in the past. And what we really hope to help to pioneer is a new model of education that will be practiced across all of our schools. So just very quickly, the old model of education was based on specialization. You stopped studying lots of things and became more expert in one thing, like a major or going to a degree in a single professional subject. But everyone knows the problems of our time have many different aspects to them. And so the student of tomorrow is going to need to be able to bring many different domains of knowledge into interaction with one another to solve problems that can't be solved in one dimension alone. This is a kind of signature of Duke's programs in really pretty much every school. I went to India this fall on Duke's behalf. India is a place famous for its engineers and famous for the training of engineers, but engineers are trained to be engineers in India. When I went there, I talked about a program we have called the Master of Engineering Management, in which students trained in engineering continue to study that subject while also taking business courses to learn how you test out a business model to see whether an engineering idea can actually be a realistic commercial venture. And they also take courses in the law school on intellectual property, so you would understand the extent to which something can or can't become the basis of a financially viable operation. That's not the way engineering is taught just everywhere around the world, but the fact that we have students from all around the world coming to Duke to enroll in that program tells you something about the kind of new needs that it meets. I would just say, secondly, we want academic education to be not just a matter of academic self-enclosure. We want it to be a place where people use their minds, but reach out and touch the real problems of the world and try to make a difference with them, starting in our own community and reaching around the world. Here I could choose a million examples, but I'll tell you what occurred to me. You are next to the ocean. I laid eyes on the ocean today for the first time in a long, long time. The last time I went somewhere that was entirely surrounded by water was also my trip to India. It may not occur to you that this is a similarity between Florida and India, that they have massive coastlines. When I went to India, besides discovering that Duke had business school partners there, healthcare partners there, all kinds of things, I discovered that the people working on a protocol to protect the health of the oceans in India had been in interaction with Duke faculty members for 10 or 15 years. And that's what you look for, a school where academic knowledge touches real-world problems and has relevance and audience both locally and all around the world. And then I think the third thing that I take to be a mark of what we're trying to promote is just this. The idea that in the future it won't be so helpful anymore to think of education as about highly authoritative people like me standing in the front of the room as everybody observes a kind of decorous but passive silence in their presence. We look to a world in which education will involve students as actors, as active participants, completely engaged in their education, people who not only learn things but use their knowledge and use it in a way that contributes to making things happen. I've chosen some engineering examples. I'll just choose one more. You may know about this extraordinary building on the Duke campus called the Smart Home. Some Duke engineering students, my first year as president, said, "We don't want to live in a dorm you built. We could invent way better systems than the ones you have in your building. Why don't you create a building, why don't you allow us to create a building where we will design better technology for everything? We'll design the fuel systems, we'll design the telecommunication systems, we'll design everything," and Duke did it. Entirely with student input, Duke built this place. 12 students now live in it, and everybody goes there. It's very cool. I myself have eaten dinner there, and Cindy and I once brought a turkey over there, which was picked very clean, I'll tell you. Such is the nature of student appetites. But it was astonishing to have these students. They don't just live in this place, they created it. Everything you see involves their solution to a problem. They took things they learned in classes and repurposed them to make things happen around them. They are the only students whose shower I have ever inspected because they invented a system to capture the heat of the hot water that runs down the drain and use it to reheat your water so you don't need to use new energy to do that. And everything in the house is just, these students live in the middle of their own ingenuity. And when they're gone, their ingenuity will be replaced by that of their successors. And I love the idea of an education. You couldn't build the smart house if you didn't take classes and do homework. But the point wasn't to do the homework, it was to learn something so that you could use it to solve a problem of relevance to yourself or others. I'll just give one last example. I got to appear in the center court in Cameron Indoor Stadium at the Miami game in the company of a young lady named Parker Goyer. So, you were a classmate of hers. She was a member of the varsity tennis team and graduated a year ago, and I was out there with her because she won a Rhodes Scholarship this year. One of her accomplishments was this. She had done an internship in Vietnam one summer, and she had the idea to go back there. She took a group of varsity athletes from Duke and UNC and went back where they team taught a class for sort of late middle school students in Vietnam, where they taught them English and physics and badminton and soccer and tennis and everything else that can be played in a sort of box-like square. How did they happen to have the courts and facilities for that, I asked. And she looked like I was quite a dull fellow. Well, looking on a website of the State Department, we discovered there were public grants for things like this, and so we competed for it and won it. So they went and built this sports facility and then ran this program. It is extraordinary to talk to these students because they're aware when they go there, Vietnam, like many Asian countries, has an educational system largely based on memorization, but they were teaching the system more like our own, with a very rich extracurricular life right next to the curricular life. And they became aware of the nature of their education. My favorite thing about the story was when they said to me, and we also learned that the things we learned in sports really were part of education, learning and teaching teamwork, learning and teaching leadership, learning and teaching how to compete in a way that advances the interests of everyone on your team. I see this just as a model of the kind of education we're seeking to promote, where we teach people, but they take it and put it to their own purposes, going out in the world and making things happen that take the benefit of Duke far beyond that of our own students. You know what? You can do a lot of that kind of work wherever your endowment is. We'll try to get it back up. Maybe someone will call me later this afternoon or evening and tell me that it's all skyrocketed again, which will be just fine. But you know, Duke was founded on the eve of the Great Depression. It has been through all kinds of circumstances, and it has flourished in all of them. And I say, why shouldn't that happen now and in the future as well? Let me break off there and begin to turn my attention to the still darkened Victor Dzau. When I get toward the end of the introduction, maybe you'll sneak up so that you will be sitting in the chair at the time that, okay, why don't you sneak up and I'll introduce you. Don't look at him. Go, sit in your usual chair. Okay. Oh, the lights have come up. Ladies and gentlemen, this is a simulation of my office. And the funny thing is, it's not that bad a simulation. Sit down, sit down. It's not that bad a simulation of my office. I have a window like this, though that building is not, in fact, outside my window. And I have 2 chairs, and the funny thing is, Victor and I talk probably 2 hours or 3 hours a week, and we had a real conversation just on Monday. Now we're going to have a staged conversation. Who is this person? Victor Dzau is the Chancellor of the Health System at Duke and one of the premier academic physicians in this country. I'll tell you something you may not know about him. I went to an event in Boston where Victor was given something called the Golden Door Award for immigrants who had made extraordinary contributions to American culture. This person was born in Singapore. His family had to decamp to Hong Kong at the time of the political changes in the late 40s. When the time came for you to go to medical school, I heard you say this, you could not go to Australia because they did not take Asian students at that point. And therefore, you are somebody who has lived modern history and indeed the history of discrimination. Your family went instead to Canada, where you started your rise as a serious student of medicine. You became a cardiologist, one of the most admired academic cardiologists in the country, as I know from many sources. But a funny thing happens to cardiologists. They end up having to run things. Everybody who runs anything at Duke seems to be a cardiologist, I said. They don't find this surprising at all. Victor ran a department. You ran the Department of Medicine when you were on the faculty at Harvard. And then came the interesting moment when you, who had had your career at Harvard, at Stanford, at Harvard, were then offered the position at Duke. I spent a memorable wintry spring evening in Boston in the company of this stranger where the 2 of us got to know each other, and I would like to hope partly as a result of that dinner, we entered our positions together in the year 2004. Since becoming chancellor at Duke, healthcare is a big business at Duke, and you have made it a very successful business. It's a fast-growing region, and you found a way to meet the needs of that region. But I think what we all feel is our proudest claim is that you have made the health system as famous as anything for quality of care, for patient safety, for regarding the humanity of the people who are our patients. Ted Kennedy is only the most famous person who went way out of his way to be treated at Duke and who called us to let us know what a fabulous experience that has been. It's not all your work, but I give you a measure of credit for it.
Thank you.
Since we are not only a hospital, but an academic hospital, it's also been an important part of Victor's accomplishment to work with his many colleagues who do research to create an atmosphere in which academic research really does enrich the world of patient care and human welfare, and you've done a lot in that regard. And then I would say, because it's in keeping with my initial remarks, Victor has helped make the health system a place of connectivity across the university, across the city, and indeed around the world. I'll just give 2 examples. There is in Beijing a university hospital system. It has 14 hospitals that are inconceivably large by American standards. The heads of those 14 hospitals came to the U.S. for a 14-day tutorial conducted at Duke to learn the management practices of an advanced medical system. They are our continuing partners, and that's a great thing. But on the other side of that scale, I had a breakfast recently where the state legislators and senators of North Carolina gathered with some of us in the Duke administration, and the question was asked, how can we solve these problems of rising medical cost without lowering medical care? And everyone was so impressed at the things Duke is doing to create new patterns of care, which I know you'll tell us something about when I ask you the appropriate question. I will now make the seamless transition to my seat, I hope, and in the meantime, please welcome my friend Victor Dzau.
How are you?
Okay, here we are, my friend.
What happened to the light?
I don't know. This is, of course, for us quite humorous and uncanny because we're sitting on stage doing something we do every week in reality and as recently as 2 days ago.
With the same seats.
With the same seats. We were careful to do that. Let me just ask you some questions, Victor, and sort of just randomly, and then just to warm these guys up so they can ask you what they really want to know. I'm just interested. You were a smart young guy, and you ended up going into a certain field, the field of cardiology. What was the thing that interested you to make you choose that specialization? How did your career take shape that way?
Well, that's interesting because I was getting my training at what is now known as Brigham Women's Hospital at Harvard. And I think this is where role models and mentors make so much difference. My mentor is Dr. Eugene Brownwell, who is really the giant in cardiology. And of course, if you look at the patient issues, patient needs, the great burden of disease, which is cardiovascular disease, it was very obvious to me that that's something I wanted to do, is to take care of patients with heart disease. Also, cardiovascular area turns out to be a unique opportunity because it's where the intersection of science and technology and patient care exist. So you know that if you look at what's happened in cardiovascular disease in the last several decades, not only can we recognize what causes heart attack, what are the risks for heart attack, that people can actually have drugs, interventions, whole variety of ways to prevent it or treat it. And we are seeing, indeed, the load of cardiovascular disease declining in this country. But we're seeing it rising in the rest of the world. And so, for me, it was just the right thing to do, a place where I can actually do what I like to do best and being able to bring in some of the newer ideas of how to do it, make a difference.
Okay, but now I come to my next question. I already gave my simplistic answer to this, so you can give the real one. You didn't set out to become a cardiologist in order to run things, right? So how did that happen?
To run things?
Yeah.
I'm not sure if I run anything.
How did it evolve? How did your career evolve in this kind of more managerial or administrative?
You know what I tell people is I'm an accidental leader. And actually, I'm on this bandwagon now.
I'm sure this is why we get along so well.
I was just earlier talking to Steve Scott, the idea that when you look at what's needed in healthcare, you need people who are doctors who can lead and manage and understand patients, but also understand the whole issue of management. And there are very few people who train that way.
That's right.
And I think I did it as really a series of accidents. Generally speaking, if you do a good deed, you're asked to do the next one, and you don't go unpunished. So what happened is, when I was doing quite well in what I was doing, someone had the idea to say, how about if you lead this division? And so I got a call from Stanford to say, would you come out and run cardiology? And when I had a lot of fun doing that, they say, how about you run medicine? And that's how, then you called me.
Then I called you. That's just what I was about to get to.
Right.
Okay, so you had, how many times had you been at Duke before you took a job there, before the interviews?
3 times.
3 times, okay. This is a question that interests me very much, which is there something about Duke medicine that's different from the way medicine is done or taught or practiced elsewhere?
Well, Duke is a very special place. So Duke always had this world-class reputation. I've been there several times, and it's got this tradition, even 80 years only, but a great tradition of quality and excellence. But I would say that what attracted me to Duke really is the people. I think the people makes up a place, its own value, its characteristics, its culture. And I think at Duke, we have this can-do attitude, outrageous ambition, youthful. There's really nothing that prevents us from doing what we like to do or what we think is the right thing to do. I have to say that since I've been at Duke for 4.5 years, it's totally exceeded my expectation. Even though it's got this world-class reputation, the kind of things that people like to work together and to succeed. So that's why Duke is known for its interdisciplinary work. People like to make a difference and to have a social impact, a civic engagement, trying to, in fact, do good in the world. People like to take science and inquisitiveness and try to put it into application. So it's, I mean, the kind of opportunity that Duke has offered, not only to me, but I think to our students and to our patients and to the world, has really totally exceeded my expectation.
Let me ask you a really easy question now.
Was that a difficult one?
No, that was not a difficult one at all. What would be your 2 or 3 minute diagnosis of the issue of healthcare in this country? I just say it with this prelude, which is that when did you first hear that healthcare was a problem in this country? And we understand the problem, that there are extraordinary high levels of possibilities of treatment, and that access to them and things of that sort are extremely unreasonable. And all the years that has been discussed, the problem has grown more than the solution. What to you is the root of the issue?
Yeah, I think that, first of all, we have to take a step back and to say, what is healthcare and what are we trying to do? And I would say that there's no perfect system, but I think the intentions, if you will, and the mission is to obviously, as we say, relieve suffering and help to treat diseases. We're clearly going much farther than that now. We're talking about wellness, health, in addition to disease. And there's no perfect system, but I think in this country, we all recognize that we have a really imbalance. There's about 50 million people who have no insurance, and we have what I think certainly President Bush would argue, the best medical care in the world. Well, that's probably true for some, but not for all. And I think that I think President Obama would say, well, we need to reform healthcare to ensure that everybody have access, and that in fact we will have the best care for everyone. And I think that's where we need to go.
Well, I guess what I'm interested in asking is, what does an academic medical center have to contribute to solving the problem of health care that a non-academic medical center doesn't have the resource for?
Well, I think, the strength of the academia is the quest after knowledge, the willingness for people to think out of the box to find solutions, bringing, as you said, science to solutions, trying to find, in fact, ways to engage the community, engage multidiscipline outside medicine, in business, in engineering, in the environment to solve this problem. And I think that is unique in this regard. We're also a kind of living laboratory where good ideas can be taken and translated into human application. So Duke is very, very, I think, advanced and is a major leader in this area. We talk about translating discoveries that our scientists make in the bench, and to say, how can we convert that to something that's relevant in treating human disease or diagnosing? And we also talk about taking the findings that you have from evidence and translate it into practice. And that's not a small feat. How do you practice evidence-based medicine? I think academic organizations like ours are uniquely positioned because we have ranging from science to delivery of primary care, from the laboratory to the population. And so I do think that academic organizations, academic health centers can be leaders in this healthcare reform.
Well, let me just ask you, you spend your life doing these things, and for me they're part of the wonder of what's open to me by my job. But for instance, when I go to your colleagues who are working in genomics, or people who talk about personalized medicine, which are, these are problems you can't solve by good policy. They really take science to get there. But tell me a little about that.
Very much so. I think if you look at what lies ahead and the opportunities, I think I can summarize the following. First of all, we all believe that first, people should have access to care. But as you and I have spoken, if we have opened up the doors tomorrow, the floodgate, in fact, we have the infrastructure and the systems that can deal with the large number of patients who need access to care. And I'll come back to that. We talk about the quality, and what you like to do is obviously to offer patients the very highest quality. And how do you, in fact, define quality, and how do you make sure you deliver that? Prevention, the importance in public health and prevention. Everybody recognizes that, in fact, and also prevention is much greater than for treatment. And so how do we actually have an effective prevention system, particularly for heart disease, for breast cancer, for many other areas? And personalized medicine. At the end of the day, there's so much variability or variation among, in this room, people with different genetic variation, different backgrounds, different ethnic backgrounds, et cetera. And how do you actually find the best care for that single individual patient? After all, as a physician, that's what we need to do, is to focus on that patient and provide best care, personalized medicine.
Well, I was really interested when I went over to the IGSP, the Institute for Genomic Science and Policy, where the people there, Joe Evans and others,
right,
were doing this work where you could sort of match people's genetic signatures with their liability to certain forms of lung cancer and their responsiveness to certain particular forms of care. So the idea that the therapy that is good for one person is actually not good for another, and you want to get the person matched with the therapy
that's right,
that gives them help. But what I found so extraordinarily interesting about that was that's a level of scientific analysis you couldn't have done a short while ago. But when they were doing it, they were already thinking of how could you put clinical trials in place to see whether this scientific evidence could be made the basis for treatment or social policy.
Yeah, no, absolutely true, because if you have lung cancer or you have breast cancer, not all the cancers are alike. And even until recently, we look at histology and say, well, you have this kind of cancer, small cell lung cancer or whatnot. But it turns out, of course, that's only pattern recognition by looking at a picture. In truth, if you begin to get the molecular signature that is getting down to know what genes are being turned on, turned off, et cetera, each one will have very specific characteristics. So they can tell you two things. One is, as President Broad has said, if you have the way to do the signature, which is what our investigators have shown, you can actually say, if you have this pattern, you're likely to have recurrence of this disease after you have actually surgery. If you have this pattern, you may not. And that makes a big difference, because whether you're going to get chemotherapy following the surgery or not is very much dependent on whether you're likely to have the disease or not. Because if you treat everybody the same way, there will be people who don't need chemotherapy. So that's a very big step forward. The other one is that if you understand the molecular pathways of a disease, you can actually take specific therapy and target that pathway. And everybody's heard of Gleevec. That's one of the kind of examples of how you're taking information from molecular level to get specific drug. So let's talk a little bit about our brain tumor center. We have a very well-known brain tumor center, the Robert Preston Tisch Brain Tumor Center. And what they do uniquely is, and that's why I think patients come, is our surgeons are the very best. And I'm not by any means exaggerating this. They're willing to say to a patient, where most doctors will say, this is not operable. They're willing to operate. The reason that most surgeons say is inoperable is because they're really worried about doing harm. That is, when you're doing a surgery of a brain tumor, you could inadvertently cut or hit some nerves in the brain, which will then impair your speech, impair your walking, so you would have done more harm than good. So our surgeons do it personalized way by actually doing when the patient's awake. And they can map the patients and actually using a variety of ways, looking at electrically mapping it, or ask the patient to wiggle your toes to speak so that they know how they're operating using image-guided operation. But that's not the end of the story, because we all know that that's not enough. That's why people say you have inoperable, because if I can remove it, I would have done it. But what the surgeon has done is to remove the mass as much as possible, leaving behind a small percent of the tumor. Now this is where personalized medicine come in. You take the tissue, the tumor tissue, and go back to the laboratory, and then analyze what's about this tumor. I just described to you, you can do molecular signature. So you can say, what is this tumor, and what is going wrong with this tumor, so we can find the right drug for it. So one idea is, one way that they've approached is to say, what is expressed on the surface of this tumor? Then you can use vaccines to target those proteins on the surface to kill the tumor. That is, I believe, personalized medicine. That is where I think that our surgeons have done so well in bringing together surgery, genomics, biology, oncology, medicine, and you know, a whole variety of multidisciplinary approach towards this.
Well, and Duke being Duke, you know it because these two world-famous surgeons sit right under the basket at all the women's basketball games.
Right.
I'll just ask you one last question, then I'll throw it open. That question really went to the question to me, answered the question: what can the science of science contribute to healthcare more broadly? But when the state legislators came over, what I found so interesting is they weren't that interested in the science of science. They were interested in the point you made that if we solve the problem of access to healthcare with our current healthcare system, actually you're just going to overwhelm it.
How do we make sure that people have access to care? So the example I give is Massachusetts. When Massachusetts said everybody needs to have mandatory health insurance or else you'll be fined, everybody got health insurance. And there's a lot of people who never saw doctors started seeing doctors, and suddenly they find they didn't have enough primary care physicians, they didn't have enough infrastructure of people just standing in line, and they're also driving up the cost. So while well-meaning people talk about reform as an economic reform, I think it's got to be the quality of care reform. So what we're pioneering at Duke is to say, look, we recognize there are not enough doctors, certainly not enough primary care doctors. I bet you in this room, a lot of people will say, I can't get an appointment with primary care doctors, right? You also recognize that when you see a doctor, you got to go to his office or her office, get a blood drawn, and then come back, and then go back to find the lab test result. They start your medication, let's say, for blood pressure. Then you go back and have it checked again, and you get all this back and forth, totally non-user friendly. So I think the way of the future is to say, look, we should treat patients in their community. We should treat patients in the workplace. We should develop a system of healthcare delivery which is not dependent on the doctor, but centered around the patient. How do you do that? Well, I think, Dick, you just remind me of all the things that we do. You know, Duke is the first school that created a physician assistant program.
That's right.
Some 30-some years ago.
That's right.
And this is the #1 program. What we've learned from our community and family medicine is that through teamwork, you can have nurse practitioners, physician assistants, doctors all work as a team. The care is given closer to the patient's home, utilizing community workers, utilizing family members, utilizing nurses, etc. But you're linked to a decision-making process by the physician, using electronic means, etc. This is what is now calling the medical homes idea. It's a very bad term, in my opinion. But the idea is that you deliver care around the patient and not around the doctor. You solve the problem of physician shortage by actually providing other healthcare workers who are highly trained but connected with the physician using good information technology. And that's what we're doing. Now, so you talk about savings. In North Carolina, this program is called CCNC, the Community Care of North Carolina. And Duke is responsible for 7 counties. Last year, when we measured the savings, it saved North Carolina, and I'm talking about the North Carolina program, not just Duke alone, right. About $150 million. And you know, Medicaid is federal matching. So that saved federal government at least that much, if not more. So all told, we saved about $300–400 million. Now, this is so exciting that President Obama's team sent David Cutler, who was this architect for his healthcare plan, to visit us. We had a chance to sit down with him and show him the program. I've subsequently also talked to him for about an hour over this program. And we also have the chance to talk to Human Services Secretary designee, who's no longer,
right.
Tom Daschle, about this. And, but I only say that mainly because I think that this is a great example of innovation based, and then using evidence, collect the evidence that you actually not only deliver better care, but you save money. That's the way to do healthcare reform. The last conversation about 10 years ago, healthcare reform, or maybe more than that, had to do with how can we do the economic reform. I think that's not the starting point. We do want to have a healthcare system that everybody can afford, but only through quality can you really bring down the cost of care.
When you're on a campus like the Duke campus, one of the wonderful, wonderful things about Duke is that the medical school and the health system is right there. So when I walk out of the president's office, I can turn left and be down among the dormitories or in the athletic complex, or I can turn right and be where you are. And the way that the doors are open to undergraduates, to business students, law students, is really one of the extraordinary assets. So, and I hope this gives you a little bit of a flavor of the kind of exciting things that just go on the average day. I meet with you every week, and I learn these things just incidentally, but they just are I think, will be the kind of thing that make the enduring difference, the enduring contribution that a great university can make. There's a lot of medical and non-medical people, and maybe it sounded like a few people who might have waited at a doctor's office in this room. So let me throw the floor open and see what you want Victor to talk about. Please.
You talked a lot about the science and the economics of healthcare. Can you talk a little bit about the ethics? When you talk about personally matching healthcare and genomics, I definitely think about not being covered by a health insurance policy in the future because my gene print might be for a Tennessee specific disease. Can you talk a little bit toward the ethics?
Absolutely. And as you know, that is a very important issue, an issue that's being closely looked at, in fact, by President Obama, because the whole issue about Privacy Act is important, and non-discrimination based on genetics. I believe this is a very important issue. It's still work in progress because the information on genetics itself is still somewhat limited. But I think in the future, when you can sequence your entire genome for $1,000, as you know, there are now companies out there for $300-some, you can actually at least do a gene chip, DNA chip, to look at some of your genes. I think so. And in fact, 2 weeks ago, I was at the World Economic Forum, and I actually moderated a session on this particular issue with Francis Collins, who sequenced the human genome, and Linda Avey, the founder of 23andMe, who have this technology. We had a good debate. At Duke, we have an institute called Genome Science and Policy, and that's why I think this is a forward-looking organization, because most places will have Institute for Genomics or Center for Human Genetics. What we've done is we bring together exactly policy, ethics, science all together to debate this, intellectual properties, many issues, and we have some of the very best.
Sorry.
And I think that it really is just the beginning of an engagement of this issue, which are absolutely important. And it's important to engage the public in this discussion.
I'll just tell you, it is an astonishing fact that we have a genomics center that has a philosopher on its staff, Alan Buchanan of our faculty. But the world is better for philosophers when they don't only live in philosophy departments. The world is better for everybody when they don't only live in departments. Departments weren't created so people could live in them. They were created so you could get the specialized knowledge that you could then bring together to solve things that have to be done together. So that's a great question to have asked. You can't have any more questions. I'm calling on the man behind you. Sir, that's you.
Dr. Dzau, thank you for mentioning the physician's assistants. We're both PAs teaching in a PA school.
Excellent.
And we're very proud that the Army was the one that first started the PA school at Duke and the Navy. We in the Army use the PAs now in the battalions, and we relieve the doctors to be in the hospitals. Since you have a lot to do with China, we just went there last year, and they're very interested in PA. Is Duke doing anything to get the Chinese thinking physician assistant to solve some of their problems?
Okay, so this is an excellent question. First of all, as far as PA school is concerned, we are actually expanding our PA school and increasing enrollment. We just moved them into a nice new building, what used to be Blue Cross Blue Shield building. We believe it's a very important part of medical care. We are engaged in discussion with China and India. And I would put it this way. I think there's learning from both sides, not just sort of, we can transfer our system to you, but in fact, there's a lot to be learned. I mean, when the Chinese had the barefoot doctors, as I'm thinking back, I said it wasn't such a bad idea, right? Because of, in fact, the opportunity for people to see the patients in their own environment and being able to deliver care closer. Well, it was not perhaps the most effective or efficient system. So I think a combination of trying to adopt what we've learned in terms of PAs and what I call teamwork medical homes. But in China, there are medical schools that train 2 years, 4 years, 6 years of, quote, medical training. They call them all doctors, which probably in our country we won't. But I think what it does tell us is that training should be adapted to the needs and closer to community. Because if you were in India, in a village in India, you would not get sufficient, well-trained, totally trained as we have in our country, workers. But they solve their problem by finding alternatives, innovation in the context of limited resources. What do? They use community workers, families. And there are programs there where people are trained in a very specific skill set. So for example, if you live in an area in which malaria is the major disease, they train people specifically. They don't know everything, but they know enough to make a difference. I'm actually doing a project, talking about World Economic Forum, in arguing that we can learn from innovation from other countries and to see how we can help them scale it up and make it sustainable, and how actually we can take some of those thinking and bring it back to our country. I think PA is an example of innovation. There's a lot more innovation out there. What I think we've done is we've built a system that is probably complicated, that is short in terms of the manpower, but perhaps training people with a skill set that's so broad that takes too many years, and some of the skill sets are never really used. So another way in the long run to solve this problem would be to look at a different way of training people altogether. And I'm not predicting what it is, but I'm just saying, simply making an observation that there are lots of innovation out there that we can learn from.
And again, I would just tell you this because I find it so fascinating. Duke is the only place I can imagine where there is a partnership between the medical school, the business school, and the divinity school based on the idea of figuring out how to produce appropriate leaders and community health workers in Africa. In Africa, there's an extraordinary shortage of health workers. Why the divinity school? Because there are parts of that country where the principal health workers are faith-based or ministers.
Yeah, exactly.
And so if you don't take them and try to give them the increment of knowledge that can help them make the difference, you're missing the chance to cultivate the resource you've actually got. That's just to me an extraordinary
And
fact.
it really happens in our backyard. I mean, many of you, since you're all Duke alum, you lived in North Carolina. We have lots of rural parts of North Carolina that have no access to health care. And so, you can argue we can train more of the same. I would argue we need to find ways which will be more effective, and that would not drive up the cost, but actually end up achieving the kind of goals we want in delivering the health care.
Good. Please.
Dr. Dzau, you brought up a great program in North Carolina that's now being taken upon by President Obama, et cetera, the CCNC. But how does a program such as that get implemented on a national scale when the economic incentives for both physicians as well as PAs and nurse practitioners is towards specialization? I mean, in my own med school class at Duke, I don't think there were more than 2 people that went into family practice. And as an instructor in the PA program here, they all want to go into dermatology. So how is it that we drive people towards those goals to actually have a program such as that?
You're absolutely right. It's an issue I think a lot about. You should read my op-ed that I wrote in December on this issue.
I read it.
And in fact, I think that we obviously have to train a lot more primary care physicians. And we also need to develop these models of care delivery that's not solely dependent on physicians. In the training of primary care physicians, you know that we need to realign incentives, right? I mean, first of all, why do people go into specialties? I heard that at Harvard this year, 16 students out of 120 some applied to dermatology, right? Excuse me.
Your inquirer is, I believe, a dermatologist.
Right. So first, our students end up with a huge debt, right? And so when you, after all these years of training, you end up with $150,000, $200,000 debt that you have to pay, your choices are going to be quite clear that you're going to have to find ways to pay that debt. And whereas in primary care, you know, you're undercompensated. There's not enough infrastructure support for it, right? And so I think that there ought to be a whole series of actions, which I'm sure that current administration is thinking about, which is how do you change reimbursement? How do you provide incentive, whether it's loan forgiveness program, if in fact you go into this specialty, or whether in fact you provide service for a few years in the rural parts of this country that you get loan forgiveness. I think that's the direction to go. It's a rebalance, if you will, of how we reward people. And I would argue that we really need more primary care physicians than we need, certainly, forgive me for saying that dermatologists at this point of time. So I think it's a fundamental issue. Most people recognize it. Now, I hope the new administration would tackle this. From my perspective, since I run a specialty hospital, actually we run really from specialty all the way to community work. I mean, we have the whole spectrum. Right. President Broadhead knows that we've engaged many discussions about how are we prepared to play a role. And so this medical homes, for example, we are rolling it to all our employees. We met with Carl Kavanaugh to talk about that. We're trying to roll it out to our other patients. We're prepared more to shift, more towards focus on prevention and delivery of care and personalized medicine.
Let me take, I'm scanning, please, in the back.
Are telemedicine and utility infrastructures connected in development and in practice? For example, atmospheric transmission of electricity and telemedicine.
Right. I think I caught telemedicine. Did I hear that right? Mm-hmm. Yeah, I think this is really a part of what we talked about using, quote, information technology. Are you aware that actually in India, 2/3 of the population have mobile phones? And so actually there is a lot of connectivity. Even if you think about the poorest part in the world, people actually have connectivity. So I think the opportunity is to use these kind of technology, develop it more further in terms of ways to actually take care of patients. Using algorithms and decision-making process. Phones are only several cents if you buy it in India. So that's what I mean by innovation. When you begin to think about innovation, people are solving problems all different ways. Telemedicine is one form of this. Telemedicine, as we understand it, would be obviously to transmit, pictures or whatever about the patient to a central resource to make clinical decisions. I believe with digital imaging and many others, and with competitive pricing, it can really go down to very low cost. I think this is where I believe the investment should be made in medicine, whereby we can really drive down the cost and improve the quality of care.
Well, listen, this is an endlessly interesting topic, and I hope you will now know my experience of realizing we're talking to an endlessly interesting person on this topic. And really what I would say is, but it's not really about you. It's about, you regard yourself as working to mobilize the resources of a great enterprise to do some good with them. And that enterprise ranges from benches where people have extraordinarily expensive, complicated pieces of machinery that do one little bit of figuring out what a subpart of a protein is, to our community centers where, you actually are the first doctor a lot of people have ever seen, and we're trying to train people, don't come to the emergency room first. Why don't you and your kids come over and they will have a reading tutorial in a place where you also get some
health checks and some advice about healthy living habits. It's that whole continuum coupled with the idea of trying to think, how can everything be done in the best way and in the most imaginative and humane way? I take it that that's your mission, and it's just a great pleasure to be your colleague, Victor. Thanks so much.
Wait, I want to say a word if I may. I want to say
You're not
that,
allowed to ask me any questions.
I want to say I truly value working with President Broadhead. I think I can't ask for a better colleague, a more understanding boss who's supportive of what we do. And it's not him learning, it's not unidirectional. I learned a lot from you and also from the rest of the university. I think it's a great place at Duke that we have the chance to work together and bring this knowledge to make a difference.
Okay. Thank you. Well, we'll be outside to answer your questions.
Produced by Duke University. Online at duke.edu.